bit of your time during what I imagine is usually a very busy lunchtime. Pathology of the with Kerry have sort of come together to develop a few educational sessions just to, as Kerry said, get the most out of your laboratory testing. And one of our most common samples, if not the most common sample in infection sciences, is urine sampling. So half the talk's about the sort of actual sampling of urine and how to get the sort of best test results for patient care. And then I've just put a few updates on the end of the slide, both on sort of testing and management of patients, and then a few other kind of little bits and pieces which I've slotted in for education as well. I'm hoping you can see my presentation.
Yes, we can.
Oh, great, brilliant. That's always nice, step one, isn't it?
It was just to let everyone know we're actually recording this as well, and so we'll take comments and questions. I don't know, Georgina, would you like to do it throughout your presentation, or would you prefer it at the end?
At the end would be lovely if that's all right. Otherwise, I tend to lose track slightly.
No problem. So yeah, if you've got any comments or questions, please put them in the chat or just hold them to the end. That'd be brilliant. Thank you.
Thank you. So as I said, we're going to talk a little bit about urine sampling, requesting, processing, management of UTIs, a little bit on special populations, and then I'm just going to do a few little other updates on our quick reference guide on Remedy and our launch of our molecular stool testing as well. So urine sampling, it's really important to send, as clean a catch as you like, as we possibly can, to avoid contamination, either from the rectal area, from the perineum, so our lab can process the samples without delay. Ideally, and I know this is difficult, especially in sort of patients who aren't particularly mobile or can be confused, or paediatric samples, but ideally we'd like a midstream urine, and this is the part that's taken actually from the middle of the stream. So ideally you collect by patient cleaning their hands, collecting in a sterile container free from detergents, and it's the first quantity of urine that's passed, which may be contaminated from the skin, and it's ideally the middle of the sample. So we've put some directions for urine sampling in women. So they should hold the labia apart, pass some urine to the toilet, pass the urine into a sterile pot, and then once the pot's near full, then pass the rest of the urine into the toilet. And then it's obviously similar for men, apart from they retract their foreskin. And then I just wondered, sort of generally, and we can talk about this after the talk, kind of what shared practice you bring to your into primary care or the community at large, into kind of directions that are given to patients, because I know it can, sort of that can be the kind of key area for patients who are able to kind of take that on board, and what we can try and improve or should share, good practice. So after the procedure, then the specimen has to be transferred into one of our boric acid tubes, and I put a picture of our green or olive, as I think they're actually formally called, and they can also be red topped, but it's always the bit of the tube that has some powder in the bottom. Screw the lid on tightly. So I form part of the rejected specimens working group in infection sciences, and a lot of our rejected specimens are actually because containers are unfortunately leaking. Then the lab pot has to have the sticker in place, and then the specimen bag. Only send a white topped universal container if the sample is less than 2 mils. That's obviously a tiny sample, usually just paediatrics. So the vast majority of samples should go in the boric acid containers, and unfortunately if it is over 2 mils, the lab will reject those just simply because it doesn't fit onto our automated machine. When you're requesting, so putting the ICE or paper form, clinical details are really important, and I'll come on to why that is later in the reporting side of things. Please include obviously the patient demographics. Clinical history is really important for processing and interpretation, particularly in this clinical situation, knowing upper urinary tract versus lower urinary tract symptoms. Please include if the patient's pregnant, again, really important for our reporting, so we give you a good and robust report that's useful for your clinical management. Other useful things are, again, antimicrobial allergy as well, so we can release the antimicrobials that are useful for your population, and any safety or biohazard considerations for the lab to enable safe processing. Again, particularly travel history is really important as well. Very, very rarely we isolate sort of quite infectious bugs from urine samples. So what do we do when we receive your sample? Well, just to give it in context, our lab receive about 100,000 urines a year. So that's a huge amount of samples. So every midstream urine will receive a microscopy where we quantify the amount of white cells, bacteria, red cells, and epithelial cells as well. So we look for white cells to give you an idea of a marker of inflammation, the urinary tract, epithelial cells to try and kind of quantify how contaminated this might be from the perineum. Bacteria as a marker of bacteria in the urine, and a red cell count as a marker of hematuria. Just because of the nature of catheter samples, we don't provide a microscopy for those because it's not useful for your clinical interpretation. And then dependent on the amounts of bacteria versus white cells versus red cells, the lab have a sort of algorithm. I'm not going to go into it now because, to be honest, it's quite complicated. And they'll either set it up for culture or they'll release a comment at this point saying, no microscopic evidence of infection. So based on the above microscopy, if it's no microscopic evidence of infection, they will not culture it because the yield of culture is very, very low in these particular patient populations. All catheter samples are cultured, however. So that's a key difference, and why it's really important to request either a midstream urine if it's midstream urine or catheter sample if it's a catheter sample of urine, because as you can see, they're processed slightly differently in the lab, and we only have your clinical details to go by. So day 2, if it's gone for culture, you'll get a culture result. So only either no growth, which means there's no bugs that have been isolated by a lab, no significant growth, which is subtly different, but means that the amount of organisms detected is essentially small and too less likely to be clinically relevant. A pure growth of a significant organism, i.e. you're getting a name of a bug and some sensitivities. And then a mixed growth, which usually by and large means that the sample has been heavily contaminated, occasionally means that there's a few bugs causing that urinary tract infection. The lab can't provide sensitivities when there's heavy mixed growths because there can be up to 3 or 4 bugs. They would have to literally manually select all of them out, then set up sensitivities. And to be honest, we'd get a lab report back with some sensitivities after the patient had completed their antimicrobials. So again, less likely to be clinically relevant for you, but a huge amount of work for the lab. So no growth samples are automatically released, so they don't go through any kind of senior biomedical scientist check or medical microbiology check. They go straight out onto ICE system. A positive result, however, i.e. one where we've isolated a bug, will go through what we call a validation period, where we, either the senior biomedical scientist, usually for the community samples, or a microbiologist, are checking the result and releasing things that are useful for you. And I'll give you some examples. So our sort of rules for releasing antimicrobials are to release everything that's resistant. So you know that that bug is resistant against the antimicrobial, and that sort of forms part of the patient's history. When you're looking back at sort of what antimicrobials are best to select for patient populations, it's really handy to know that things are resistant, for example. We usually try and give 1 beta-lactam option, so 1 penicillin-based option and 1 non-beta-lactam. And we always try and release gentamicin in our gram-negatives, just in case the patient comes into hospital, because that's our first line intravenous antibiotic. We will also try and review the clinical details, i.e. pregnancy, beta-lactam, allergy, upper urinary or lower urinary tract. And again, that's why it's really important to put those, because we do look at them and we try and kind of supply you with some useful reporting there too, either to see if we need to do further sensitivity testing or sort of write a useful comment to try and guide your treatment options. So this is a nice straightforward option. So this is how it looks in our lab system. It obviously looks slightly different when you come onto ICE. So you can see we've given you white blood cell count, red blood cell count, with count of the epithelial cells and the amount of bacteria, which in this urine isolate is very, very high. We've grown 10 to the 5 of E. coli, pure growth. Everything in brackets will be automatically suppressed. So if we wanted to release, say, coamoxiclav, because you'd put that the patient was on coamoxiclav, one of us would have to manually go in and release that for you. And everything outside the brackets you can see. So you can see here the patient's on pivmecillinam, the E. coli is susceptible to pivmecillinam, so that's good news. They had nitrofurantoin for a UTI, but symptoms have returned. So really useful clinical details for myself and my colleagues to review this urine sample was sensitive to the nitrofurantoin they were on and the pivmecillinam that they're now on. We've got gentamicin just in case things come into hospital. That's good to go. That would go straight out. Now, this one's not so straightforward. So we've got query UTI, and then we've got, a microscopy count as well, consistent with UTI, but you can't diagnose that just by microscopy itself. And then we've got an E. coli, and everything in red is resistant. So you can see this particular E. coli has developed resistances to quite a broad straight range of antimicrobials. So for example, all our kind of pyelonephritis community options are resistant here. So coamoxiclav, cefalexin, ciprofloxacin. It's also resistant to pivmecillinam. Your only options are nitrofurantoin and gentamicin in the community. So if you had, for example, renal impairment, that would be a tricky option. Suppressed at this point are fosfomycin. So if I was validating this as a microbiologist, I'd release that so you could see that. And tazocin, which is an intravenous option that you wouldn't be reaching for in the community, but we'd always release that anyway, just in case they came into hospital. So this one, if they had renal impairment, you'd probably be calling us up for other antimicrobial options, and we'd be sort of trying to explain that unfortunately there aren't any oral other options for sort of a pyelonephritis. So it might be that they had to come into hospital for intravenous antibiotics. But, the minutiae of that doesn't really matter. It's more that sort of giving our kind of thought patterns when we're validating this, and how important clinical details are as well for our interpretation to provide a useful report for you. So management, I'm just going to briefly go over and just signpost and highlight things. So upper and lower urinary tract infection, BNSG has great community guidelines on remedy, which are hopefully easily accessible, and I think are due for review by Liz Jonas imminently. And I think also there's some nice UTI guidelines coming out as well. So in adults who aren't pregnant, lower UTI, first line is nitro or trimethoprim. Lower UTI, increased risk of resistance. So for example, those who have had multiple courses of antibiotics or in nursing home, then we release pivmecillinam, which is a penicillin-based antibiotic, cefalexin or fosfomycin as an option as well. Acute pyelonephritis, cefalexin, coamoxiclav or ciprofloxacin. And there's also some good management options on recurrent UTI, which I'll come on to as well. So results versus management, and what I mean by this is when you get a result, how do you manage and what the sort of pathway or algorithm is. So if the and this is a very sort of straightforward, practical way of thinking about it. So, and I'm sure you're all very aware, if the treatment option is not listed that the patient's on, you can obviously give us a call, and we also have an email as well for non-urgent queries. So I know that a lot of your results get checked out of our hours, i.e. the lab's still up and running, but the clinical advice would be going to an on-call registrar who covers a few hospitals. So we do have a generic email, and I've put it there. Have I? Yes, I have, and it's also on the Remedy website. So if you're happy with the next day clinical answer, then you're very, very welcome to answer us, and we do try and answer by the next working day at least. You can also obviously give us a call via the clinical advice line, but I appreciate that does take a little time to get through sometimes. If the isolate's resistant to the particular bug, the patient may have improved just by their own immunology, so give a patient a call if they're on the incorrect antimicrobial. If they've not improved, and again, you can give us a call for clinical advice or email as well. If the bacteria is isolated, but if a bacteria is isolated on the urine sample, but the patient actually doesn't have symptoms and signs of a UTI, outside of pregnancy, we wouldn't really advocate treatment for this patient unless there are other complicating factors, like they were just about to have a urological procedure or they're immunosuppressed and the immunology team are very keen to treat. But again, these patients were very happy to discuss on an individual basis, but for most patients, asymptomatic bacteria outside of pregnancy or young children doesn't require treating. So a little bit on recurrent UTIs. So as I said, Remedy includes some very good guidelines on management and or management and investigation of recurrent UTIs, including red flag symptoms. And I've put the link there. So it's essentially defined as 3 or more UTIs in a year or 2 in 6 months, and contains some red flag symptoms when to refer. So things like neurological symptoms, any man with recurrent UTI, isolation of Proteus, which can be which is a bug which is associated with stone formation. And it also includes some really useful measures on prevention of recurrence as well. So simple measures such as hydration, treatment of constipation. There's guidelines on non-infective anti-infective measures such as topical estrogen in perimenopausal or postmenopausal women. Then we go on to the antimicrobial options, so single dose trigger of antimicrobials. So when there's an obvious trigger for a UTI, this can sometimes be in our sort of younger population, then they can have a rescue pack of antimicrobials to have at home. And then there's the other things, so continual antimicrobial prophylaxis, so particularly nitrofurantoin or trimethoprim. When we talk about continuous antimicrobial prophylaxis, we usually say, well, we do say to review at the 3-month mark. No antimicrobial was without side effects, as I'm sure you're aware. There's been MHRA guidance on management of prophylactic antibiotics, particularly monitoring of nitrofurantoin with pulmonary function tests and blood tests, and also trimethoprim of monitoring of used knees and FBCs as well. But the remedy guidelines contains really nice, clear guidelines on that. Just this mini update on quinolones as well, whilst we're talking about the MHRA. As I'm sure the prescribers are aware, there's been a recent update or alert on quinolone prescribing. So the primary care guidelines have been reviewed to sort of essentially make sure that the indications for quinolone prescribing still stands. But essentially, just as a summary, so quinolones can cause quite disabling tendinitis, although rarely. It can lower seizure threshold, so a lot of caution in prescribing with patients with epilepsy. It can also prolong the QT interval as well, so patients who are on lots of QT prolonging drugs, there should be caution with that as well. Ideally shouldn't be used for uncomplicated cystitis unless the other antimicrobial options aren't suitable, i.e. the bug's resistant to that. Try and avoid in patients who've had a previous reaction, avoid concomitant use of steroids with quinolones, because that's thought to increase the tendinitis risk, and obviously discontinue promptly when side effects occur. Essentially, quinolones are really useful and good group of antimicrobials, are really effective in pyelonephritis as well. So if that is the best option for the patient, I think the upshot of the MHRA, sorry about that, warning is to essentially, it's part of the patient conversation to explain the risk versus benefits of starting them on a quinolone. And there's a really useful patient leaflet as well that can accompany and hopefully help and support your prescribing decision. Again, microbiology always happy to discuss via phone or email if that is the best option for your patient. And I think it just highlights, we've got now warnings for nitrofurantoin, quinolones. I'll talk a little bit about pivmecillinam. I think penicillin allergy delabeling is very useful. Most patients, or some patients, can have their penicillin allergy delabeled via history alone. I can do a little mini update later in the year about penicillin allergy delabeling if that would be useful. And the British Immunology Society have recently given really good guidance on how to do this via a scoring system via history for those sort of patients who are low risk of having anaphylaxis to penicillin. So when we talk about penicillin, so talking about pivmecillinam, a sort of small update on that as well. So it's a penicillin-based antimicrobial that's used in UTI for its gram-negative cover. Very, very rarely can be associated with carnitin deficiency, which it's contained within muscles and can cause muscle weakness and can affect not only skeletal but respiratory and cardiac muscle as well. Very recently, our biochemistry team at MBT highlighted there'd been some diagnosis of carnitine deficiency in in some of our pregnant women and in our newborns as well, that had been associated with pregnant women taking pivmecillinam during pregnancy. It also interferes with the newborn screening spot test for screening isovaleric aciduria, which I'm sure you all remember affects leucine metabolism, which essentially meant that the newborns had to have a second line test. So it can cause false positive tests. So for this reason, again, the pivmecillinam prescribing in the local area was reviewed. It's not contained, so pivmecillinam isn't advocated in pregnancy first line in any of our community guidelines, and it didn't appear that the patients who had prescribed it were sort of on microbiology advice. But again, it just gives a little warning about, you know, considering pivmecillinam in pregnancy, and if you are considering it, again, discuss with us about if there are alternate options. We in the lab, to help support that decision-making tool, and hopefully in the next few weeks or so, we will suppress pivmecillinam where the clinical details say pregnancy, or the urines, for example, come from our midwife colleagues. Again, just to nudge you in the right direction, in this case, away from pivmecillinam prescribing. So hopefully that should support with that. But again, it comes to clinical details. If we don't know that the urine has come from a pregnant woman because pregnancy hasn't been written on the urine sample, then we wouldn't know to suppress that for you, to help you. So again, just hijacking the talk a little bit to promote the Remedy pages. So we've tried to, with the Remedy team, update the infection or microbiology pages. We brought microbiology and ID together on those pages and just put some useful useful updates on things like the new mpox clade. I've also put a Remedy quick reference test guide, which should hopefully provide a visual summary of what swab goes for what bug or what test that you're looking for. Please do provide us with any feedback either on the infection pages. If you want anything else, or they're not clear, or out of date, then do email through our lab microbiology generic email, and we'll try and update those at least annually. And then the last thing I was just going to mention is our stool testing algorithm has changed as well, and that was in the last month or so. I think that went live. So stool MCNS has changed, and we now have a very faster turnaround time molecular target, which will hopefully, as I said, improve turnaround times, because we're not trying to grow the bugs up for you, and also is looking for more targets as well. It does mean that the requesting for stools has changed. So if you're encountering any problems or think things could be improved, or it's not quite clear or working for you in primary care, then do again let us know. And I've put our email there as well. And that was the end of everything I was going to say.
Georgina, thank you so much. There is a question in the chat. I've put a couple of things in the chat as well, just as we were talking about some links.
Oh, thank you.
The question is the RCC count an accurate marker of hematuria?
I mean, it is for that sample. It's an automated microscopy sample, and I thought I was going to get a question on hematuria, because we sometimes get this through our sort of microbiology inquiries, and I can send our sort of cut-offs and how we do that, because I know it's very important, not particularly from a micro point of view, i.e. an infective point of view, but it's useful for sort of microscopic hematuria when you're thinking of referring patients onwards for urology. So I can, if you're happy, Kerry, I can send that information onwards for you, if you're happy to receive that.
Yeah, that'd be brilliant. Thank you. A couple of things that came up when you were talking. So questions we've had in the past is around what if the demographic details are incorrect on ICE, and that was a question I had in ICE meeting today. And basically, if any of the demographic details are incorrect for your patients, you just need to email the ICE teams, and they will change that, because they will get some information from the spine. So there shouldn't be anything that you have to do yourself. So you can't change anything on ICE. It just has to be noted that needs to be changed, and to email to the ICE teams. And the other question that I had was around actually getting samples from a paediatric perspective, you know, those advice and guidance of how to do that. Now I've put the UTI children management and referral guidelines from Remedy on there, but I just wondered if there's any further information that you know, just so we can share it with individuals and parents. I know there are some sort of parent apps of how to do it, but I suppose it's if there's any top tips that we can share.
Yeah, I mean, having personally gone through that with my child, it's so difficult, and I wish I had a magic tool. Obviously, with boys, it's a little bit easier, and maybe it's just a bit of a waiting game. With girls, it can be even trickier. If they're wearing nappies, you know, it's not the ideal specimen, but we will, you know, any urine that you send us, even if it's taken from their nappy, we will process. But again, put that in the clinical details just so we can help with our sort of interpretation of when we get, you know, lots of mixed bugs, etc., etc. But yeah, that's why I specifically hadn't talked about the paediatric population, because it's very difficult one for getting a sample when they're, you know, tiny, and also the treatment is different, and the threshold for treatment is different as well.
Thank you. Question was, if a patient develops a UTI even on long-term antibiotic prophylaxis, would you continue the same long-term antibiotic treatment?
Yeah, that's a good question. That's often a question that comes to us in microbiology as well. As I said, every prophylactic antibiotic needs that 3-month review to make sure they're getting the proper monitoring, which is all listed in the Remedy guidelines, which I skipped over quite quickly. But, you know, for example, with nitrofurantoin, it's the pulmonary function tests and bloods, particularly LFTs as well. My question, I always try and put that question back to the patient. So if they're getting some relief from, say, they used to get 12 UTIs a year, it's gone down to 2 UTIs a year on their prophylaxis, and it's working for them, there's an argument to continue. If they're getting breakthrough UTIs, you know, despite prophylaxis, they either need to stop it, go on to something else. But more importantly, from my perspective, is investigating and making sure we investigated into reversible causes of UTI. So, you know, is there a tumour? Is there a stone? Do they need further workup from that point of view? Topical estrogen in perimenopausal women. So, you know, if it's just the one UTI, but generally it's working for them, they're having all their proper monitoring, they've been counselled against potential side effects, then there's definitely an argument for continuing. But I think it just is a good option, is a good moment in that patient's care to review whether that antimicrobial is still appropriate for them.
Thank you. Rebecca, you've got your hand up.
Yeah, thank you, Kerry. Just wanted to ask you a couple of questions, Georgina, about the samples. You mentioned that if we can't get 2 mils, we can send it in a white one. Is that only for children, or can you do that for adults as well? Because they often get sent back as incorrect pot, even if you do send it. Do you need to put something on it to make sure that you...
So if it's less than 2 mils, so we'll only process a specimen in the white top if it's less than 2 mils. If you've sent it in a white top and it's, you know, filled to the top, for example, we'll reject it because the white tops don't fit on our automated urine processing system. Does that make sense? Have I understood your question correctly?
So basically you said for a paediatric where we may not be able to get that amount, we can send it in a white top one?
If it's less than 2 mils.
Yeah.
So that's a tiny amount, isn't it?
Okay, and you might sometimes have that for adults if they've got an infection and they're only passing very small amounts. But if we send it in a white one, it gets rejected because it's not in the right container. Is there a way of identifying the sample so that you know we've not been able to get enough for a olive coloured one?
No, I mean, we should process it if it's less than 2 mils. That's very useful, though. I can take that back to the lab and sort of just make sure we're doing that properly for you. And again, if you're getting any, if you've got an example of that you can remember, or, you know, in the future, if you get an example of that, just email through and we can look into that just to make sure we're not accidentally or incorrectly rejecting your specimens, because we should be processing them if there's a small amount in a white top, regardless of age group.
Thank you. And my other question was a little bit similar to the long-term antibiotics. If we've treated someone with the 3 days recommended antibiotics and it's, you know, it's sensitive to that, but they still haven't got rid of the infection, would you carry on then with the same antibiotic? Is there any benefit to changing it to another one that is sensitive to? Or would you just then repeat?
Do you mean they still have symptoms, but it's better on the antibiotic? I think there is, yeah. I mean, these durations aren't fixed and the bugs don't understand calendars. So I think, you know what I mean? And this is sort of all epidemiological, and, you know, the courses are evidence-based, but I think for individual patients that they've got better, we know the bug's susceptible, you could argue to continue on longer. But then in the back of my mind, I'm thinking, oh, why are they outside the normal patient group? Is it because they've got something else underlying that could be reversed, and all these sort of examples I've given before? So again, it kind of comes back to, it's a bit of a trigger in your mind to just make sure that they've had their appropriate scans and investigations.
Yeah, I think it's mainly the older population. If you give them just 3 days, for some patients that just doesn't seem to be enough.
Yeah.
So I was just wondering whether you should just continue with the same one, or
yeah,
but yeah,
no, I
obviously
think it's fine
considering all the
continue.
other.
Yeah, and in the older population, obviously, immune system plays a part, constipation plays a big part as well. So again, it's kind of trying to hit those reversible causes. But I think that would be a fine situation. You know, I wouldn't go against that.
I just have one other quick question. We get our patients to hand in a white top and an olive in case we want to dip the sample. I know you haven't mentioned dipping the sample, but I know I have heard some surgeries are dipping the olive or the red ones. I assume that would skew the results from the urine dipstick.
Yeah, I think it does. I've looked into this before, and I think it changes the results of the nitrates particularly. But when I looked into this, is about 2 or 3 years ago. But yeah, either way, because of the chemical additive to it, I'd recommend dipping it to the white top. So if anytime you could educate them, your colleagues, that would be really helpful.
Yeah, no, that's fine. We're still asking for 2 samples, so I just wanted to clarify that was the best thing to do, because we're trying to reduce the samples we send to you by using the dipsticks if we can.
Yeah, absolutely.
Yeah, perfect. Thank you very much. Sorry to ask so many questions.
No, it's great. I'm glad you were listening and engaged.
Is there any further questions from anyone at all while we're here? Give it a couple of seconds. Whilst you're thinking, one of the things that we come across around is like generic email addresses. So what about rejected stuff? How do we know about it? And obviously, I think for me, one of the key things is making sure that practices and PCNs have generic email addresses so that the labs can email them back with any questions or queries. Sometimes if it's just professional, individual specific, then obviously if that individual's away, if they're on annual leave or things aren't being sort of monitored, then there comes issues. So we've actually just gone round to all practices and PCNs and asked for generic email addresses. We're going to go out again for some more, because this is really helpful for the labs to have those within their sort of access and range, so they can actually just contact you as soon as they can, rather than you just waiting and finding out has it been rejected or not and why. So it's just to highlight that.
Great. No, that sounds very useful.
And I think that's it from my perspective. Let me just make sure there's nothing else in the chat. Can you send stool samples to check for threadworms?
No, so it has to be the special threadworm kit, which you can get from our lab. And again, I've put a picture of the threadworm kit on the quick reference guide as well.
Thank you. Brilliant. Now I know that's a quick round. That was half an hour instead of an hour, but I think it would be good just to obviously give you guys some time back at practice if there's no further questions.